Okay, thank you for your invitation. With particular cases, this is a male, 27 years old. He has been operated in another center for a retinal detachment involving the macula in an optic peak pathology. In 2007, he performed a pars plana vitrectomy with lens sparing and ILM peeling, a laser around the optic disc, and tamponade with SF6 and 20%. He referred her to our center for an recurrence of the retinal detachment with a visual acuity of 20/50. And in the OCT, the image is this one. So this is the surgery. Start. Okay. This is the case. We can see the pit. We use the dye to check the status of the posterior hyaloid. It was eliminated till the principal vascular arcades. So we start to removing the remnants of the ILM, of the posterior hyaloid. Then we check the status of the ILM, finding that on the vascular arcades and not in the center. Using some bubble of PFCL, we have to manage the plugs of ILM inside the optic pit to try a fibrosis, a closure of the pit. So this is the plug of ILM inside the pit. At the end, we can remove the bubble of PFCL, tamponade with the hair, and at the end, only an SF6 and 20%. This is the evolution of the case. In 10 months, the visual acuity reaches 20/20, and a resolution of the fluid under the macula in the horizontal scan of the OCT, and permanent of little fluid on the superior part of the macula. Thank you for your attention.
Thank you, Tomaso. So we can discuss every case.
Okay.
Because, no, stay there. Because we are in different cases, so it's better to discuss each one. So first question is, what kind of surgery was made before? The first
one, the first
the hyaloid was there, the internal limiting membrane was there.
No, the first surgery that he has made in another center.
Yes, but
they removed the ILM. They had laser around the optic nerve and gas tamponade.
Yes, but I saw that the hyaloid was there, so I was wondering.
The hyaloid was at the external of the arcades.
Mm-hmm.
In the center of the macula, there was not hyaloid and no ILM.
Okay,
they keep everything till the arcades.
Right. What kind of secret you have to avoid the plug escape?
The bubble of PSCL to manage it. One time inside the optic pit, the hyaloid and the plugs of ILM find his fine position and is great.
Right. Any comments from the floor? Barbara, do you like to add any comment?
Okay, so we have seen in the session when we were discussing optic pit detachment, my question was, do you think there is a risk for the PFCL to go through the optic pit? As it is, it's mentioned in the literature that even silicone oil can migrate.
Yeah, but we try to not put the PFCL directly on over the optic nerve. So when the bubble is complete, and it has a great dimension, I don't think that we can have the risk to go inside the pit that is very little.
And when you aspirate PFCl, the ILM flap stays there.
Yeah, because we try to not aspirate the PFCl directly over the optic nerve. We try to...
On a side.
Yeah, on the side, tilting the high bulb and dislocated the bubble over the arcades, over the macula, and not trying to, because the risk is clear, is to lose the plug.
My doubt is, do you think it's really necessary to put the ILM flap inside? Because sometimes we make some flaps, but after a while we see them floating on top of the pit.
Yeah, we have tried inside cases, but in this case in particular, we have not found any kind of ILM over the posterior pole. So we have not able to have a flap to overlapping the optic disc. So we have to find something over the arcades, as we see in the video, and putting in like we have in the recurrence macular hole with transplantation, autologous transplantation of the ILM.
Okay.
Okay, thank you.
Just a question. I didn't understand. You said that you didn't find the ELM in the nasal quadrant, and so you decide to choose other places, or in your opinion it's possible to make a flap from the nasal quadrant and
the
put it on?
flap is good when you find, I think, when you find the ILM with a good consistency in the posterior pole, so you can peel and overlapping it. But in this case, all the posterior pole till the arcades, as we can see, was cleaning by the hyaloids and ILM.
And using the ILM of the nasal part?
Yeah, we have taken the ILM from another part. But
no, nasal.
In the nasal, we don't think about it. We have think about searching over the arcades and putting in.
Because the ELM, when you stay outside the vessel, it become thinner.
We know.
It's different from the posterior.
We know it's different, but we know that finding the ILM out of the arcades can induce better fibrosis.
Why?
Because we have seen in some cases of the recurrence macular hole with plug of ILM transplanted till the arcades, we have seen that inside the macular hole, the process of fibrosis is bigger than the flap of ILM finding around the hole. And so we think if the fibrosis the cicatrization is better, we can have better results in these cases when we want to close a hole at the end and not having performer of visual acuity.
And another observation, I think that the PFCl will not pass through the optic disc because of the superficial tension that is completely different from silicone oil tension. And silicone oil, when you put inside the eyes, can make not only emulsification, but also dispersion of the tiny bubble from the surface due to the different superficial tension, especially when there are some products that induce this.
Yeah, I agree.